Sleep is the quiet engine that keeps the nation running. It repairs tissues like a meticulous mechanic, files memories like a careful librarian, and balances hormones like a disciplined treasurer. When it breaks, society pays. On highways, in factories, in hospitals, in homes, fatigue becomes a tax on attention and a surcharge on every decision. That is why a sound that seems harmless, a rattling snore in the dark, can be the first domino in a chain that leads to clinics, coded claims, and contracts measured in billions. Snoring is not always a medical condition, but when the snoring belongs to a body whose airway repeatedly collapses overnight, starving the blood of oxygen and jolting the heart like a false alarm, it has a name that insurers recognize: obstructive sleep apnea. It is common, it is consequential, and it is expensive when ignored. A decade of public health campaigns has repeated the same warning. Left untreated, obstructive sleep apnea raises the risk of hypertension, heart disease, stroke, diabetes, depression, and accidents. The American Academy of Sleep Medicine has estimated that nearly 30 million Americans have obstructive sleep apnea, with roughly 4 out of 5 cases going undiagnosed, generating economic losses measured in the hundreds of billions each year through healthcare utilization, crashes, and lost productivity. Before a snore becomes a medical bill, there is a threshold question in American coverage. Is this medically necessary? That phrase is not poetry, it is policy. For obstructive sleep apnea, Medicare's National Coverage Determination established a blueprint most private insurers follow. It turns on a number called the Apnea-Hypopnea Index, or AHI, the count of breathing disruptions per hour of sleep. Medicare covers continuous positive airway pressure when the AHI is 15 or higher, or when it is between 5 and 14, accompanied by symptoms such as excessive daytime sleepiness or comorbidities like hypertension, ischemic heart disease, impaired cognition, mood disorder, or a history of stroke. That is the hinge on which 1,000 prior authorizations swing. How do you prove a number that happens while you are unconscious? You measure it. There are 2 paths. One is the gold standard, attended overnight polysomnography in a lab. The other is an at-home test that uses fewer channels but captures the essential respiratory signals. Each path has its own billing codes and price reality. In-lab polysomnography is billed under current procedural terminology, codes 95810 or 95811, with the latter code used when treatment such as continuous positive airway pressure is initiated during the same night. Home sleep apnea testing typically falls under code 95806. These dry numbers determine what appears on an explanation of benefits and whether a family owes hundreds or thousands. The price spread is a lesson in American health economics. An at-home study can cost a few $100s. An in-lab study can be billed at over $1,000 and sometimes far higher depending on network status and facility markups. In some markets, published ranges for home tests hover near $200, while facility-based studies are contracted near $1,000, and consumer cost trackers show in-lab ranges climbing into several $1,000s cash. The sticker price is not the same as what insurers pay, but the point stands. The same diagnosis can take the on-ramp of a lower-cost home test or the toll road of a lab study, and the choice is shaped by policy and clinical judgment as much as by a patient's symptoms. The path to durable therapy runs through a second gate: adherence. Coverage for machines is not set it and forget it. Medicare, and plans that mirror it, turn payment into a trial. For the first 12 weeks, the clock is running. To keep coverage beyond that, the patient must return to the clinician for documentation of benefit and must show objective device data proving use for at least 4 hours per night on at least 70% of nights during a consecutive 30-day window. Within the first 90 days, it is the closest thing health insurance has to a gym attendance policy, and the devices themselves now report usage through digital modems and memory cards to verify compliance. The machines sit in a special corner of the payment system called durable medical equipment. Here, the economics are different. The most common device is coded as E0601 for a single-level continuous positive airway pressure device. Medicare does not buy it outright on day one. It rents, month by month. After 13 continuous months of rental payments, Ownership transfers to the patient, while Medicare continues to cover masks, filters, tubing, and reasonable service. To the patient, the plan's copay is a steady drip. To the supplier, it is a predictable revenue stream that rewards adherence data and relentless logistics. This is where a snore becomes a business model. Suppliers and manufacturers live by modifiers and months. In the first 3 months, claims carry a KX modifier, attesting that all coverage criteria are met. As months tick by, rental modifiers march across the claim. KH for the first month, KI for months 2 and 3, KJ for months 4 through 13. Everyone in the chain speaks in this specialized shorthand because revenue depends on it. 2 multinational companies tower over the treatment landscape. ResMed, born in Australia and headquartered in San Diego, sells masks and machines and cloud services that track compliance. Its sales run into the billions each year, a function of chronic disease prevalence and a reimbursement model that rewards recurring supplies. Philips, through its Philips Respironics unit, has been the other giant. Its trajectory was jolted in 2021 when it recalled millions of devices over concern that polyurethane foam inside certain machines could degrade. The Food and Drug Administration later summarized testing and, in 2024, announced a consent decree that restricted certain U.S. production and required a remediation plan to repair, replace, or refund affected devices. This was not just an engineering problem. It was an insurance and trust problem. Patients needed replacements, suppliers needed inventory, and payers needed to know what they were financing. The diagnosis itself has a history of debate. In 2022, the U.S. Preventive Services Task Force concluded that there was insufficient evidence to recommend routine screening for obstructive sleep apnea in asymptomatic adults. In plain language, the task force said there is not enough proof that screening everyone without symptoms does more good than harm. That has real consequences. Screening recommendations influence employer wellness programs, insurer coverage rules, and physician practice. At the same time, specialty societies continue to emphasize the disease burden and consequences of missed cases. A policy landscape with tension is a landscape where patients can fall through the cracks. To understand how a household meets that landscape, follow the money. A primary care visit leads to a referral. A home test is ordered because it is cheaper and often sufficient. If the test meets criteria, the prior authorization is submitted. The device arrives with a mask that may or may not fit. The first nights are awkward. Dry mouth, pressure discomfort, leaks that hiss like a kettle. A respiratory therapist tweaks the ramp settings and humidity, swaps a nasal cushion for a full face mask, and coaches the patient through the first month. If the device logs 4 hours a night on enough nights, the claim stream continues and ownership arrives after 13 months. If not, coverage can stop, the machine can be retrieved, and the snore that started as a nuisance becomes a renewed medical mystery. The rules are indifferent to excuses. The data must be there. The billing architecture is intricate. The sleep lab bills the polysomnogram under code 95810 or 95811. If it is a split-night study, where diagnosis and treatment occur in the same night, the guidance is to bill the single code 95811, since it is inclusive of 95810. For shorter recordings, a modifier 52 may be used to indicate reduced services. The home study is 95806. The device is E0601. The masks and accessories are separate supply codes billed at regular replacement intervals. It is an alphabet that keeps revenue cycling like a conveyor belt. Scale makes markets. The global sleep apnea device market measures in the billions of dollars and grows each year as diagnosis increases, as obesity rises, and as technology makes home testing easier. ResMed reports quarterly revenue in the hundreds of millions to over $1 billion, with analysts parsing growth in masks, devices, and software as a service. Investors debate whether new classes of weight loss drugs will shrink the addressable market by reducing obesity and therefore apnea severity. Executives counter that even substantial weight loss often does not eliminate obstructive sleep apnea completely, that adherence still matters, and that untreated disease remains dangerous. The market is not just hardware, it is data, replenishment, and adherence coaching. For patients, The economics have texture. Deductibles and coinsurance apply. A Medicare beneficiary pays 20% of the Medicare-approved amount for the machine rental and supplies after the Part B deductible. A commercial member in a high-deductible plan may find the first month painful and the rest manageable. Out-of-network facilities can turn a test into a bill that looks like a car payment. The safest move is the unglamorous one. Confirm network status, ask for CPT and HCPCS codes up front. Request the contracted rates. If a home test will adequately answer the clinical question, choose the lower cost path. The difference between a 3-figure home test and a 4-figure facility study is not just abstract economics. It is the difference between paying rent and staying current on a prescription. Masks, too, are economics on a face. They wear out. Headgear stretches, cushions tear, filters discolor. Every replacement has a cadence in policy. Suppliers build businesses on this churn, while patients build rituals around cleaning and replacement. For many, the therapy becomes a nightly pact. If the machine keeps the airway open, the brain will file its memories, and the heart will beat more steadily through the night. Critics argue that the system medicalizes snoring too quickly, that a vast apparatus stands ready to convert a sound into a syndrome and a device into a subscription. Supporters respond that untreated apnea is not just snoring. It is intermittent hypoxia, surges in sympathetic tone, endothelial dysfunction, and measurable cardiovascular risk. The evidence base is messy in places, but it is not empty. Medicare's adherence rule did not appear by accident. It emerged from studies showing that 4 or more hours per night is a minimum threshold for clinical benefit, and from the practical need to prevent closets full of unused devices purchased on public or pooled dollars. The recall at Philips Respironics added a layer of hard truth. Medical technology is not invincible. Foams degrade, supply chains fail, consent decrees happen, patients lost trust, clinicians scrambled, and competitors gained share. In that chaos, one lesson resurfaced. When a device becomes part of a nightly vital function, safety communication must be transparent. Remediation must be swift, and payers must adapt so that patients are not punished for corporate mistakes. The Food and Drug Administration's public updates and the court-ordered production limits were a reminder that regulatory oversight is not a footnote. It is the guardrail. There is also the uncomfortable question of who gets tested and who does not. The Preventive Services Task Force's I statement on routine screening means many adults will only be evaluated if someone listens carefully to their story. Loud snoring, witnessed pauses in breathing, morning headaches, daytime sleepiness, resistant hypertension. The public health estimate that tens of millions are undiagnosed is not just a statistic, it is a map of who is not sleeping, who is crashing cars, and who is developing silent vascular disease. Coverage rules that are designed to curb waste can inadvertently harden access barriers when primary care is overburdened. In this way, the economics of apnea are also the economics of attention. And that returns us to the bedroom where the story began. A partner nudges a shoulder, the snore stops for a moment. A breath returns. For some, that scene is just a habit. For others, it is a medical signpost pointing toward a diagnostic test, a trial of pressure, and a stack of claims whose codes tell the whole journey. The system is far from perfect, but the rules are legible if you know where to look. Here is the rulebook written in plain English. If snoring comes with symptoms like daytime sleepiness, gasping arousals, or uncontrolled hypertension, ask about a home sleep apnea test first. If the result shows an apnea-hypopnea index in the Medicare coverage range, know the next step is a 3-month trial where the device must be used 4 hours a night on at least 70% of nights to keep coverage. Know that the machine will rent month by month, transferring ownership after 13 months if you keep using it, and that masks and filters will be on a schedule. And know the names that will appear in your search results and bills. ResMed, Philips Respironics, local durable medical equipment suppliers, and the sleep lab whose CPT codes tell you what you are buying. Sleep is vital. If a snore is a symptom, do not ignore it. But do not stumble blindly through the billing maze either. Ask for the codes. Confirm the network. Choose the least costly test that answers the clinical question. Meet the adherence target early, and make the device work for you, not the other way around. The takeaway is simple. Protect your sleep like your life depends on it, because it does. And protect your wallet by learning the rules before the first bill arrives.